How was the gaucho guy?
Oh, very good. I had a taste of the Argentinian. Uh,
Whose phone is that?
okay, can we start?
Okay po. Ah, good morning. Rinig po?
Yes, Leandro, go ahead.
Okay po. Okay, so good morning. We are subset group 5 and we are here to present the case about elevated transaminases. So for our salient features, it's about a 50-year-old female patient who works as a dialysis nurse because of elevated transaminase noted on her workup for her hypertension. She has been having rises in her blood pressure since 2003 and is on medication with metoprolol 50 milligrams tablet but she takes it irregularly. Her blood sugar also was noted to be elevated 2 years ago, but she did not receive any treatment, but instead her physician advised her to do exercise and weight reduction. She occasionally takes celecoxib for her joint pains. On physical exam, she is ambulatory and coherent. She has a height of 160 centimeters and a weight of 78 kilos. And her BMI is noted to be 30 kilograms per meter squared, in which in the Asia Pacific classification, it is classified as obese type 2. Her vital signs are stable except that we have to note that her blood pressure is 160 over 100 and she has a slightly high respiratory rate, but her pulse rate is normal with 75 beats per minute regular and she's a febrile. She also has pink palpebral conjunctiva. Her neck veins are not distended. She has a dynamic precordium. Apex beat is at fifth left intercostal space mid-clavicular line, sustained and not diffused. She has normal heart sounds and no murmurs. Her lungs and abdomen are unremarkable and no pedal edema. So before we proceed to the main discussion of the case, let us have first an overview of what liver function tests are. So there are a number of tests that are used to evaluate liver function, and this includes biochemical tests, radiologic tests, and pathologic tests. But for our case for today, let's focus first on the serum biochemical test, which is also commonly referred as the liver function test. And this can be used to detect the presence of
Um,
a liver disease.
Leandro, sorry.
Yes, Doc.
Can you repeat that sentence? Liver biochemical tests are also liver function tests.
They are
You said
commonly
that.
referred.
Well, what does liver, as the name implies, what does it test? Ano tinetest niya?
Ano, Doc,
Function.
yung, yes, Doc, different
Function, diba?
functions of the,
So,
Apo,
so going to that through that line,
Apo.
will your, let's say, your aminotransferase, does it reflect the function of the liver?
No, Doc, it only detects the liver damage po or interference sa bile flow po.
Yes. So I think that should be a very important distinction. Liver
Yes po.
function test is the function of the liver, whether it's synthetic or excretory function. Yun yung tinetest ng liver function test. While the other tests, you have to distinguish kasi they do not check the function.
Yes po.
They are reflective of something else.
Yes, Doc. Okay, noted po.
Okay.
Okay, for our liver function test, it detects the presence of a liver disease. It distinguishes among different types of liver disorders. It gauges the extent of a known liver damage and follow response of treatment. However, it is important to take note that these tests lack sensitivity and specificity. Why? They can be normal in patients with serious liver disease, but they can also be abnormal in patients with diseases that do not affect the liver. And these tests rarely suggest specific disease, Rather, they suggest a general category of liver disease which can either be hepatocellular or cholestatic. And as I have said a while ago, this the liver carries a lot of biochemical functions, and these laboratory tests only measure a limited number of these functions. And it is important to take note that there is no single specific biochemical test to accurately assess the liver's total functional capacity. That's why, in order to increase the sensitivity and specificity of this biochemical test, we need to use this standard battery of tests, which includes the bilirubin, the total and direct, the albumin, prothrombin time, the aminotransferases, AST and ALT, and these enzymes such as alkaline phosphatase, gamma glutamyl transferase, and 5' nucleotidase. So, I'll briefly
Leandro,
discuss. Yes, po.
the GGT and the nucleotidase are not standard. Just
Okay po.
to we don't
Okay
usually
po.
check for them.
Okay po. Noted. Okay, so I'll just briefly discuss this liver function test. So, first is the serum bilirubin. We know that the bilirubin is a product of heme metabolism, and it is found in two fractions, such as the unconjugated and the conjugated fraction. Um, the elevation of the unconjugated fraction usually is rarely due to a liver disease. Rather, it is seen primarily in hemolytic disorders. In contrast to that, the conjugated fraction, this is the one that is almost always implies a liver or biliary tract disease. But in most liver disease, both bilirubin fractions tend to be elevated. And this serum bilirubin is important in a number of conditions such as the viral hepatitis. So the higher the serum bilirubin, the greater the hepatocellular damage. It also correlates with poor outcomes when it comes to alcoholic hepatitis, and it is also used to estimate the survival in patients with end-stage liver disease and to assess the operative risk of patients with cirrhosis. Next are the albumin, globulin, and prothrombin time, which are tests that measures the biosynthetic function of the liver. Only the alpha and beta globulin are the ones that are synthesized by the liver because the gamma globulin is synthesized by the B lymphocytes. And it is important to note that hypoalbuminemia indicates chronic liver disease and cirrhosis, although this is not specific for liver disease because hypoalbuminemia can be seen in protein malnutrition, nephrotic syndrome, and other chronic infections. And these three enzymes, the ALP, GGT, and 5' nucleotidase, reflects a cholestatic disease. Next are the aminotransferases, which is considered as the most sensitive markers for acute hepatocellular injury, and it consists of alanine aminotransferase and aspartate aminotransferase. So first, the ALT, it is the one which has a greatest concentration in the liver, and it is the more specific for liver injury compared to AST. While the AST is also found in many organs, such as the one that are listed here, but it is listed in decreasing order of concentration, meaning that as AST still found in greater concentration in the liver. Hello, nawala po ba? Hello?
Yes, go ahead.
Okay po,
Continue.
okay po. Okay po. So for the normal normal values, normal values for aminotransferases are vary widely among laboratories, but according to Schlesinger, in men, the normal value is equal or less than 30 units per liter, while for women, it is less than or equal to 19 units per liter. But according to Harrison's, it ranges from 10 to 40 units per liter. So for the approach to patients with elevated transaminases, let us first focus on the table here on the left side. So any type of liver cell injury can cause modest elevations in serum aminotransferases, but levels up to 300 units per liter are non-specific and may be found in any type of liver disorder. However, striking elevations, meaning transaminases levels greater than 1,000 units per liter, occurs almost exclusively in disorders with extensive hepatocellular injuries such as viral hepatitis, ischemic liver injury caused by prolonged hypotension or acute heart failure, and toxin or drug-induced liver injury. We can also
Um,
use the
Leandros,
yes po,
just to emphasize, the viral
yes po.
hepatitis here is for acute viral hepatitis, ha?
Okay po,
Not for the chronic infection.
okay po. Okay, noted po.
Okay, continue.
Sige
Yes,
po.
Dr. Ruiz.
Yeah. Also to emphasize, kasi in your table, it just says viral hepatitis A to E. A to E
Opo.
pala yun, sorry. I
Okay.
thought it's A and E. So
Opo.
again, hepatitis B, if it's acute, can also present with more than 1,000, but not for chronic. Okay.
Okay po.
Okay.
So if the acute viral hepatitis has acute transaminase of 1,000 units per liter, so we can also use the AST and ALT ratio in which ratio of less than 1 can be found can have a possible condition of chronic naman, chronic viral hepatitis or non-alcoholic fatty liver disease. While ratio of greater than 1 can be found in can be noted in cirrhosis. And it is important to take note that a ratio greater than 2 is to 1 suggests alcoholic liver disease, while if it reaches greater than 3 is to 1, it is highly suggestive of alcoholic liver disease. So for the algorithm on the left, it is on the right, it is found in Schlesinger, and it is important to note that the first step in the evaluation of mildly elevated serum aminotransferases is to repeat the test according to persistence of the elevated value. So if the aminotransferases remains elevated, we can look here in the algorithm. So first we need to take a careful history, focus on identifying the patient's medications such as the over-the-counter medications, or complementary and alternative medications, or if the patient has a history of substance abuse. Because almost any medication, including these drugs that I have mentioned, has the potential to elevate serum aminotransferase levels. So we can only rule in the drugs as the cause of these elevated transaminases if the enzyme levels return to normal after stopping this medication. Um, Muscle disease should also be excluded by obtaining the serum creatine kinase enzymes and the aldolase enzymes. So if getting history in this medication still unreveals the cause of elevated transaminases, so the next step is to assess the patient for a more common and treatable causes of liver disease. So we can test for this one, the hepatitis profile, if we suspect the patient for having chronic hepatitis B or C, or we can test for the iron and the total iron binding capacity if we suspect patients of hemochromatosis, or these antibodies such as the antinuclear antibody, smooth muscle antibody, and this one, the serum protein electrophoresis if we are suspecting patients for autoimmune hepatitis, the ceruloplasmin patients if we suspect patients of Wilson's disease, and we can utilize the right upper quadrant ultrasound if we suspect patients with non-alcoholic fatty liver disease. So if any of these tests highly favors a certain diagnosis from any of these liver conditions that I have mentioned, then the clinician can direct his or her evaluation by requesting any of the tests mentioned here on the side po. This one. But if testing for a more common and treatable diseases still unreveals a diagnosis, then we can when we can assess the patient for the lesser common causes of liver disease such as the alpha 1 antitrypsin deficiency and other extrahepatic causes such as thyroid disease and celiac disease. But if these disorders still are negative, or we don't have if we can still provide diagnosis, then the decision to perform a liver biopsy is determined by the degree of aminotransferase elevation, such as levels greater than 2 times the upper limit of normal. Then we can utilize liver biopsy with the recognition that the results of the biopsy are unlikely to alter the management. That's all.
Okay. Okay, Leandro, before you go, um, this is good, okay, because your topic is approach to patients with elevated transaminases. But
Yes.
before you do this, you said that you need to do a battery of liver, quote unquote, liver function test.
Yes po.
What we probably also would like to know is whether there is a distinction between something that is cholestatic or patient is having a primary liver injury or
Yes po.
necrosis. Therefore, what would be those uh, laboratory that will tell you that this is cholestatic or this is hepatocellular? There is an algorithm in Harrison.
Opo.
Have you look at that algorithm? If you have
Ye-
an elevation of your alkaline phosphatase
yes,
in
Doc.
greater proportion compared to ALT and AST, or on the
Yes.
other hand, the reverse.
Yes po. Here, meron po dito sa Harrison's po.
Okay, so could you tell us and your classmates how to go about this?
Um, okay. So for the liver test, if there is an isolated elevation of the alkaline phosphatase, then we
Or
can
in greater proportion compared to ALT and
about
AST?
AST, then we can direct our diagnosis, or we can direct our presumptive diagnosis to a cholestatic type of
Okay.
um or
How,
biliary type of disease po.
okay. How about the reverse?
If it is the reverse, if the aminotransferases are greater in amount compared to the alkaline phosphatase, then we could direct our diagnosis, or um we can say that the liver disease is of hepatocellular or in origin po, or there is
Okay.
hepatocellular injury.
Okay, thank you, Leandro. We
Thank you.
actually are going ahead because this will be the topic in uh, next next Friday. Okay,
Okay po.
in patients with obstructive jaundice. Okay, so who's the next speaker? Very
Thank you,
good,
doctor. Thank
Leandro.
you po.
Hello po.
Yes,
Hello. Okay.
that
So, yes po. To continue, the pattern in aminotransferase elevation can be helped diagnostically. Given the patient's ALT level, we can categorize it under chronic mild elevation with the ALT still less than 150 units per liter. And among those listed, we focused on the three common causes of elevated serum aminotransferase levels. These are chronic viral hepatitis, autoimmune hepatitis, and non-alcoholic fatty liver disease. So just an overview, we considered chronic viral hepatitis because, again, it has a high prevalence rate. And one of its extrahepatic complications is joint pain or arthralgia, which is present in our patient. Arthralgia is actually a common manifestation in these three diagnoses. We also considered autoimmune hepatitis because it commonly
wait,
affects,
wait, wait, cut.
yes, doc.
What else in the history that will tend you to to take into consideration chronic viral hep? What in the
Pwede,
subject data?
doc, the occupation of the patient.
Okay. What
She
is the
can be
occupation of the patient again?
she can be susceptible because she's a dialysis nurse.
Okay, sige. Go
Yes po,
ahead.
doc. Also, we considered autoimmune hepatitis because commonly it affects young to middle-aged women, And patients can present with asymptomatic transaminitis. Again, this can manifest with arthralgia. And a common comorbid condition is hypertension.
And
Lastly,
what else?
ano po yun, Doc?
What else in the subjective data aside from hypertension that will tend to favor non-alcoholic fatty liver disease?
As well as yung elevated blood sugar po niya.
Okay.
Yes po.
Okay. Go on.
And for non-alcoholic fatty liver disease, we considered this because, again, of its high prevalence rate, especially during the 4th to 6th decade of life. Majority of cases also are asymptomatic, and non-alcoholic fatty liver disease has a strong association with obesity, insulin resistance, and hypertension. Also, according to Schlesinger and Fortrans, Wilson disease will most likely be considered for patients between 5 to 25 years old, but it can also be considered for individuals in other ages for elevated transaminase levels that remain unexplained after other causes are excluded. As for the other hepatic and extrahepatic causes, these are less common and shall be considered if testing for the more common causes fails to provide a diagnosis.
Okay.
Good morning po.
Good
So
morning.
the next four of us will be discussing chronic viral hepatitis as the first differential diagnosis for our patient presenting with elevated ALT. But before I go into that, let me first define what chronic hepatitis is. So chronic hepatitis represents hepatic inflammation and necrosis for at least 6 months, caused by a series of liver disorders. Three categories have been recognized, and these are chronic viral, drug-induced, and autoimmune chronic hepatitis. Now, classification, on the other hand, would be based on cause, grade, and stage. For cause, you have the following: viral, drug-induced, and autoimmune, and cryptogenic. Although in Harrison's, these cryptogenic cases are also believed to represent autoimmune chronic hepatitis. For grading, you may grade it into either mild, moderate, or severe. Grade is a histologic assessment of necroinflammatory activity, and it is based on the liver biopsy of the patient. So stage would reflect the level of progression of the disease, and it is based on the degree of fibrosis. So, chronic viral hepatitis is caused by the following: hepatitis B, C, and D superimposed on B. We should keep in mind that hepatitis A and E, which are both enterically transmitted and are both self-limiting diseases, thus do not cause chronic hepatitis. But there has been rare reports where hepatitis A was said to have served as a trigger for autoimmune hepatitis, and hepatitis E was said to have caused chronic liver disease in immunocompromised hosts. So in chronic hepatitis B, the likelihood that the infection becomes chronic depends on the age at which a person becomes infected. So if you acquire the disease at birth, acute infection is clinically silent, but there is a 90% chance of chronic infection. In comparison to those who acquire it during young adulthood, acute infection will be clinically apparent, but there is only approximately 1% chance of chronic infection. Now, most cases of chronic hepatitis B among adults occur in those individuals who actually has no recognized episode of clinically apparent acute hepatitis. It is also important to remember that the level of your HBV DNA will correlate with the level of liver injury and the risk of progression. There are two types of your chronic hepatitis B, and these are your HB antigen reactive and HB antigen negative, which will be further discussed later at the serology part of the discussion. So, chronic hepatitis C follow hepatitis C in 50 to 70% of cases. Even though there is a return to normal of your aminotransferase levels after acute hepatitis, progression to chronic infection is still common. In the majority, chronic hepatitis C tends to have a very slow and insidious progression, but 25% of cases, chronic hepatitis C will eventually progress to end-stage cirrhosis. So for chronic hepatitis D, on the other hand, remember that hepatitis D virus requires hepatitis B virus for its replication. That is why it only occurs simultaneously with Hepa B, which is called co-infection, or there may be a superinfection, meaning there is already chronic hepatitis B infection, and then you acquire Hepa D infection on top of that. So in co-infection, your Hepa D may increase the severity of acute Hepa B, but it does not increase the likelihood of progression into chronic hepatitis B. But in superinfection, there will be worsening of the liver disease. Now, some cases of hepatitis C and D are positive for autoantibodies, and these are anti-LKM1, which stands for anti-liver kidney microsomes type 1 for Hepa C, and anti-LKM3 for Hepa D. Autoantibodies are uncommon for Hepa B on the other hand.
Very good.
Thank you, Doc.
Hello? Okay.
Yes.
So, Apo. So we move to epidemiology. So the World Health Organization reported that in 2015, there were 257 million people who have chronic hepatitis B infection. It resulted in 887,000 deaths, mostly due to cirrhosis and hepatocellular carcinoma. In highly endemic areas, the most common mode of transmission is horizontal or perinatal transmission. So in the Philippines, the HBs antigen seroprevalence is 16.7%, which corresponds to 7.3 million adults. So that's why the Philippines is still classified as hyperendemic for chronic hepatitis B. So for its prevalence, it's highest in the 20 to 29 age groups, but it declines in older age groups. It is also highest among those who have low annual income or those who have low educational status. So for the serologic interpretation, chronic hepatitis B, the HB antigen, which um, which denotes infection remains detectable beyond 6 months. So is shown on this is shown here in red line. Next, the anti-HBC, which indicates immune which de- which indicates immune response, is primarily of the IgG class. Um, it, it is because, as you can see, the IgM here decreases early in the duration of the infection. Next, the anti-HBs. It is undetectable or detectable in low levels. That's why it can be used to differentiate acute from chronic. Because in acute hepatitis B infection, there is the presence of the anti-HBs, which could mean immunity or protection, while it is not seen on chronic hepatitis B infection.
Uh, excuse, Maria.
Okay.
Can you
Yes,
again
Dr. Wang.
regarding immunity?
Hello po.
Can you repeat your last statement regarding immunity? You were pointing out.
Anti-HBC.
So you're saying, what were you saying about the anti-HBC?
Um, the in chronic hepatitis B, the anti-HBC is primarily of the IgG class. It is
Okay.
because the IgM anti-HBC usually decreases early in the duration of the infection. So, um, so,
Yes,
so it's
Dr. Rui.
primarily
Yeah, Noiri, I think you have to emphasize that what you are explaining as far as anti-HBC is concerned is that in chronic hepatitis B, anti-HBC is primarily of the IgG class.
yes,
'Di ba? That's what you're saying. And then
yes, doc.
IgM would decrease after the acute stage.
Yes, po, doc.
You should emphasize na in chronic hep B,
Yes, po.
anti-HBC is primarily of the IgG class. But I think what should be cleared is her statement on anti-HBS. Stephen, can you clarify? Can you repeat your statement on anti-HBS, Noiri?
Um, it can be used to differentiate acute from chronic hepatitis B infection because in acute hepatitis B infection,
Yun yung,
the presence of anti-HBs
Diba?
within
Yun yung medyo malabo.
yeah. So you're saying that anti-HBS can distinguish between acute and chronic?
uh,
Is that what you're
not
saying?
um not really po, doc. Pero
That was your. Mhm.
what I'm saying po is the anti-HBs is seen on the acute hepatitis B because it has immunity. It can develop immunity, while in chronic there is no anti-HBs.
Well, what if you get the acute hepatitis B as an infant, and if you get it perinatally, and you happen to check for hepatitis B, that's still acute because the definition of chronic hepatitis, as mentioned earlier, the duration should be at least 6 months. In hepatitis B, the definition is that you should have HBs antigen for at least 6 months. So kung infant, you happen to check for the HBs antigen since it's not 6 months pa, that will still be acute. So the anti-HBs happens, the recovery, as mentioned earlier, is more likely if you get infected as an adult, diba?
Oh,
Kaya,
yes,
kaya sinasabi nyo, pag acute hepatitis B, HBs. While in perinatal infection, usually they progress to chronic hepatitis B infection. That's why you don't see this upper portion of your figure where patients who are perinatally infected magkakaroon ng anti-HBs. That's what you're saying.
yeah, po.
But you just have to understand, um, the anti-HBs is a protective antibody. Yes, diba?
Yes, po.
Yeah,
But
that is what is written by Dr. Chan.
hmm.
Everybody, can you see what Dr. Chan wrote?
So the anti-HBs implies immunity if you are negative for HBs antigen. And if you look at my lecture, you would it was being emphasized there. Now the anti-HBC, you also mentioned, Maria, about the anti-HBC. Sabi mo IgM anti-HBC is for acute hepatitis B. I agree with you in areas where, especially in our case where it's endemic, sometimes you can also have reappearance of your IgM if you have chronic hepatitis B. So if you have chronic hepatitis B,
Yes, doc. I have a
karoon
slide
ng
for that.
flare, meaning your ALT became very, very, okay?
Hello po.
Sige, choppy audio ko?
Yes.
Okay, so, yeah, I just type it siguro.
Okay,
Sige, proceed.
can we move on?
Okay. So for chronic hepatitis B infection, we can divide the stages into replicative and the non-replicative stage. The replicative stage just means that there is positive HBe antigen, which is a marker of replication. So, wait lang po. So let's focus our attention on this graph. If you notice, this graph is a little bit incomplete because if we will talk about the perinatal transmission, it should include the immune tolerance phase, which can't be seen on this graph because this graph already starts with the immune clearance phase. Wait lang po. So in immune tolerance phase, the HBe antigen is positive and there is also high levels of HBV DNA indicating high infectivity, but the ALT is normal. This is because the immune system of the newborns is still immature that it cannot act against the virus infected hepatocytes. So the ALT is still normal. Next, the next phase is the immune clearance phase. According to Schlesinger, it occurs on the fourth to sixth decade of life. In here, the immune system can already kill the virus and the hepatocytes, so you can see the increase in ALT, which could mean that there is liver injury already. So, so this is the increased ALT. This is the presence of HBe antigen, and the HBV DNA. So next. Okay. So we already know that the non-replicative stage means negative of HBe antigen. This is because of the seroconversion that happens when the immune system is successful in killing the virus. The HBe antigen becomes positive. Ah, the HBe antigen becomes negative and the anti-HBe becomes positive. This seroconversion usually coincides with the transient increase in the aminotransferase activity that reflects the cell-mediated immune clearance of the virus-infected hepatocytes. So in here, the HBV DNA will also decrease, which leads to subsequent decrease in the immune-mediated destruction of the hepatocytes, thereby decreasing the ALT levels to normal, as you can see here. There is only limited infectivity, and in this stage, it is called the inactive carrier stage. Okay, the non-replicative phase, in about 20 to 30% of the patients, reactivation happens. It is it happens it happens the HBV, however, ALT and HBV DNA levels. So this can still progress to liver injury. Also, it is important
That
to
is
remember
why, Neri,
about
sorry, that is why it's important to put there relatively. In your book, it says relatively replicative phase, relatively non-replicative phase. To in relation to HB antigen positive patients. In HB antigen negative patients, they usually have lower replication compared to positive patients. But it doesn't mean that there's no replication. And that is why in your third bullet point, DNA can also sometimes increase still, especially in the reactivation phase.
yes, noted.
Okay, proceed.
Okay po. So it is important to remember that IgM anti-HBC may reappear during flares, wherein the ALT levels will increase greater than 5 times the upper normal limit, or in acute reactivation of chronic hepatitis B. That is why you cannot rely on IgG anti-HBC or IgM anti-HBC to distinguish whether it is an acute or a chronic infection. So in such cases, history and additional follow-up monitoring is necessary. That's it.
Hello, good morning.
Okay,
So
Becca.
most individuals with chronic hepatitis B do not have any symptoms, and if symptoms do appear, They are similar to the symptoms of acute infection, but they can also be a sign of advanced liver disease. So the most common symptom is fatigue, and they can also experience persistent or intermittent jaundice. So, as said by Nori a while ago, hepatitis B is the result of the interaction between the virus and the host immune response. So, when this happens, there will be an abrupt rise in ALT levels, up to 5 times the normal limit, and then the aminotransferase levels will have a modest elevation. ALT tends to be more elevated than AST. Alkaline phosphatase can be normal or increased. There is hyperbilirubinemia, which is also a parameter of cholestasis. Hypoalbuminemia, showing a decreased function of hepatic synthesis. Prolonged PT, in which the coagulation factors may be affected. However, hyperglobulinemia and detectable circulating autoantibodies are distinctly absent in chronic hepatitis B, in contrast to our next differential, which would be autoimmune hepatitis. So here you can see a liver biopsy of the chronic HBV infection, and this is characterized by mononuclear cell infiltration in the portal tracts. So here you can see, section B. Here in this picture, you can see that there are ground glass inclusions in the hepatocytes, which are the only histological feature noted in routine light microscopy that is specific for chronic hepatitis B. So ayan, yung mga ground glass inclusions. So these inclusions represent large amounts of hepatitis B surface antigen in the endoplasmic reticulum. And on the right, we have an immunohistochemical stain for the hepatitis B surface antigen. Note the brownish inclusions correspond to the ground glass inclusions seen on the left picture. Ayan. So next we have our complications. So as a consequence, free breakfast daw. Anyway, as a consequence, we would have intrahepatic complications such as cirrhosis and its complications such as ascites edema, bleeding, gastroesophageal varices, hepatic encephalopathy, coagulopathy, hypersplenism. So this will be more further elaborated in our SGD po. And then cirrhosis can lead to hepatocellular carcinoma due to chronic inflammation and cellular dysplasia. And then fulminant hepatitis B, in which there is massive liver necrosis. So, in our extrahepatic complications, in which seen in our patient is arthralgia or joint pains and arthritis, and the others would be leukocytoclastic vasculitis, immune complex glomerulonephritis, and polyarteritis nodosa. Thank you.
Thank you, Becca.
Hello. Hello.
Yes, yes, Jack.
Good morning. Good morning, doctors. So, the main goal of treatment of chronic hepatitis B is long-term suppression of viral replication in order to forestall progression of liver disease, to prevent such as cirrhosis, liver failure, and hepatocellular carcinoma, and to increase survival. So here is a table lifted from Harrison's, which shows treatment recommendations of chronic hepatitis B. And this table is based on the practice guidelines of the American Association for the Study of Liver Diseases and the European Association for the Study of the Liver. So for patients with reactive hepatitis B E antigen and those with greater than 20,000 units per ml of hepatitis B virus DNA, but less than or equal to twice the upper limit of normal of ALT, antiviral therapy is not recommended currently because liver disease during these conditions tend to be mild or inactive clinically. However, If the patient is above 40 years old and with family history of hepatocellular carcinoma, or the ALT is persistently at the high end of the twofold range, a liver biopsy may be done to help in the decision to treat. In patients with the same level of hepatitis B virus DNA but greater than twice the upper limit of normal of ALT, treatment is recommended. The recommended treatment for this condition are entecavir or tenofovir or pegylated interferon. Entecavir and tenofovir are oral agents with high barriers to resistance. On the other hand, no treatment is recommended for inactive hepatitis B carriers or those that have undetectable HBe antigen with normal ALT and HBV DNA less than or equal to 2000. If HBe antigen negative but has hepatitis B virus DNA of greater than 1000 units per milliliter and twice the upper limit of normal of ALT, liver biopsy should be considered to help in arriving to treat if substantial liver injury is present. Because HBe antigen seroconversion is not an option in these cases, the goal of therapy is to suppress hepatitis B virus DNA and maintain a normal ALT. For patients with compensated cirrhosis, treatment is recommended regardless of hepatitis B antigen status and ALT levels, as long as the HBV DNA is detectable at less than 2,000 units per milliliter. And lastly, for patients with decompensated cirrhosis, treatment is recommended regardless of the serologic and biochemical status, as long as the hepatitis B virus DNA is detectable. They should also be evaluated as candidates for liver transplantation.
Uh,
So there are
okay.
um,
Go ahead. Sorry.
okay po. So there are 7 drugs that have been approved for treatment of chronic hepatitis B, namely interferon alpha and pegylated interferon is currently used nowadays. And the nucleoside analogs, for example, the lamivudine, adefovir dipivoxil, entecavir, tadivudine, and tenofovir disoproxil fumarate. So, pegylated interferon is a long-acting interferon bound to polyethylene glycol and is administered weekly through subcutaneous injection. Nucleoside analogs, on the other hand, suppress HBV replication through an inhibitory effect on the viral DNA polymerase and is taken daily and orally. When it comes to tolerability, pegylated interferon is poorly tolerated due to its adverse effects like systemic flu-like symptoms, bone marrow suppression, emotional lability, and autoimmune reactions. It is also associated with acute hepatitis like elevation in aminotransferase activity, which is postulated to result from enhanced cytolytic T cell clearance of hepatitis B virus infected hepatocytes. Thus, intensive monitoring is important as compared to okay po. As compared to nucleoside analogs that are more well tolerated and requires only limited monitoring, except for adefovir and tenofovir, which may be nephrotoxic. Thus, it is recommended to do creatinine monitoring. The duration of therapy for pegylated interferon is finite with 48 weeks duration, and nucleoside analogs are taken indefinitely in most patients. Although nucleoside analogs are less likely to result in HBe antigen and HBsAg responses during the first year of therapy as compared to pegylated interferon, treatment with nucleoside analogs tends to be extended beyond the first year, and by the end of
Yes,
the second.
Dr. Wong. Sorry, Nina. Dr. Wong what's the question?
Yeah. But I think we don't need to really emphasize on interferon anymore because it's not readily available. Nobody ever uses it anymore.
Yes
So
po.
let's just stick with the nucleoside analog siguro.
So
It's of
continue ko na lang.
historical yung interferon is just for historical significance na lang.
Okay po.
And
Continue ko na lang po
maybe
yung
just tell us,
nucleoside
yeah,
analog.
maybe just tell us why you mentioned earlier that tenofovir and entecavir are the drug of choices. Why are they the drug of choices for hepatitis B?
Entecavir po and tenofovir are the drug of choices because they exhibit high barrier to resistance. So, yung for antiviral resistance po, for focusing on this part, yung lamivudine has the highest rate of resistance with approximately 30% in the first year, increasing to 70% in the fifth year, then followed by
Okay.
telbuvudine,
Okay.
entecavir.
Yes, Nia. Dr. Chan, do you have additional question?
No, I would like to ask Nina, because although pegylated interferon is rarely used nowadays, it has also a specific indication. When is pegylated interferon used? So what population would benefit from the pegylated interferon?
According to Harrison's po, Doc, hello?
Yes, according to Harrison.
According to Harrison's
Um, According to Harrison's po, Doc, there is seroconversion from hepatitis B antigen to anti-HBe, which occurred in 20% and in the early trials.
I'm just asking who would benefit from pegylated interferon if given the choice. What is most commonly used now would be your nucleoside analogs, but there's still a population that would benefit from the use of pegylated interferon. Sino to? Di ba?
Yung,
Is it in your book? Di ba?
yes
Female.
po.
Di ba? Those who want finite treatment, those especially if the females who are planning to get pregnant. Diba? Tapos if the patients of female elevated ALT, DNA not significantly high, these are the individuals who would benefit from pegylated interferon.
Yes, according to Harrison's po, pegylated interferon is used for immunocompetent adults with HBe antigen reactive chronic hepatitis B who tend to have high level of hepatitis B virus DNA with greater than 10 raised to 5 to 10 raised to 6 virions per milliliters. Tapos po, for special cases like pregnant patients, since nucleoside analogs have pregnancy category of ranging from B to C, pegylated interferon can be used for them.
Okay,
good.
very good.
No, I disagree with that. Well, anyway, like I said, peg interferon, siguro just remove that from your minds unless maybe in the future
Okay,
there's
Dr.
new
Wong, sige,
studies
we heard you, Dr.
that will
Wong.
make
Ah,
maybe unless there's future studies that will say peg interferon will be still helpful. But in any case, for you mentioned about pregnant women, tenofovir for pregnant women, especially in the third trimester where the DNA is very high, you want to prevent vaccination failures. So tenofovir is safe. Lamivudine is also safe for pregnant
Yes
women
po.
if you have to give
Doc,
it. Okay.
according to Schleisingers, lamivudine it can be used to pregnant patients.
Yes, but we don't use lamivudine anymore because, as you've mentioned, antiviral resistance is very high.
Yes po.
okay, sige.
Okay.
Let's move on. Your last slide, Nina.
Okay, so for the last slide, how will we know if the patient is responding well to the treatment? So there are
Siguro we can just focus on your nucleoside analog.
okay po. So there are predefined virological, serological, biochemical, and histological endpoints which are used to evaluate response to treatment. So focusing on nucleoside analogs, virological response requires suppression of hepatitis B virus DNA to undetectable levels for at least 6 months after treatment. Serological response requires HB antigen loss and seroconversion, and HBs antigen loss and seroconversion. Biochemical response requires normalization of ALT levels based on the traditional upper limit of normal, which is approximately 40 units per liters. And lastly, histologic response, which requires decrease in necroinflammatory activity without worsening in fibrosis, or a 2-point or greater improvement in the necroinflammatory score.
Okay, Dr. D, you have a question?
Yes, Jara, you mentioned response to treatment, and I appreciate this very much. My question to you is, when do you stop treatment?
Um,
You mentioned that already in PEG interferon, which Dr. Wong doesn't use anymore. How long?
Doc, for pegylated interferon po, it is finite, 48 weeks po yung
Okay,
duration ng treatment.
how about the nucleoside analog? When
For
do you stop?
nucleoside analogs po, since there is a indefinite duration of treatment, according to Harrison's, oral agents we oral agents, cessation of treatment for oral agents require virologic and biochemical responses. Usually po, indicate yung sa HBs antigen seroconversion. So, parang kapag po na-convert na yung HBs antigen to anti-HBs, we can
Which
stop the treatment po.
which can be forever.
Opo, wala po siyang definite wala siyang definite time.
Okay, so just to be clear to everybody, what do you mean by seroconversion of HBAG loss and HBs seroconversion?
Kapag po yung hepatitis B antigen becomes anti-HBe,
Okay,
um,
and the
and
E
then
antigen becomes
anti-HBs po.
anti-HBe and anti-HBs. Okay,
Yes
sige.
po.
So, are you the last member?
For chronic Hep B po,
Yes.
yes po.
So, why do you think your patient elevated ALT is probably due to chronic hepatitis B?
Doc, considering po the occupation of the patient, since dialysis nurse po siya, she is repeatedly exposed to blood or blood products, and she is also at risk for needle stick injury. So that would be a big contributing factor po.
Dr. Ruiz? Yes, Dr. Ruiz? Oh, she's yes, Dr. D.
Yeah, I think Jara, I again your reasoning is good, is correct, except that you may want to add in ALT that is mildly elevated.
Yes po,
Okay.
kasama din po.
Yun ang
Okay.
first reason mo. Yun ang first reason mo. And then, in a patient with mildly elevated transaminases, we considered chronic hepatitis B because of the following blah, 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 blah. All right?
Yes po. Opo.
What's blah blah blah, Dr. D?
The patient being a dialysis nurse, the patient having a exposure and all of this.
And also the patient is a Pinoy. A
Pinoy.
Pinay.
Yeah.
Yeah. What is
Yes.
our prevalence rate?
It's 16%, 16.5.
Okay, sige. Yes, Dr. Ruiz, you're back.
Yeah. That's also my comment that in the Philippines, all those with mild elevation of your transaminase should have the benefit of testing for the possibility of chronic Hep B.
Okay.
So,
Sige. So
just to
let's
emphasize.
Let's go to the next group.
Good morning po, doctors. Ay,
Morning.
si Doc D po ba may
Yes,
question?
Gillian. Yes, Dr. D.
No more, no more. Sorry, sorry.
Okay.
Okay po. So, for the next differential diagnosis, we have autoimmune hepatitis. Basically, autoimmune hepatitis is the resulting inflammation of the liver because they are being attacked by the body's own immune cells. According to Harrison's, autoimmune hepatitis is a chronic disorder characterized by continuing hepatocellular necrosis and inflammation, usually with fibrosis, which can progress to cirrhosis and eventually liver failure. So the prominence of extrahepatic features of autoimmunity and seroimmunologic abnormalities in autoimmune hepatitis supports an autoimmune process in its pathogenesis. And to diagnose autoimmune hepatitis, cases in which hepatotropic viruses, metabolic or genetic derangements, and hepatotoxic drugs should have been excluded. And according to Schlesinger, um, autoimmune hepatitis is a disease of an unknown cause characterized by the presence of interface hepatitis, also known as piecemeal necrosis, which is the hallmark of autoimmune hepatitis, lymphoplastic, lymphoplasmacytic infiltration on histologic examination, hypergamma globulinemia, and autoantibodies. And similar to Harrison's, the diagnosis of autoimmune hepatitis requires the exclusion of other chronic liver diseases that have similar features, such as chronic viral hepatitis, drug-induced liver disease, and etc. So for the epidemiology, autoimmune hepatitis has a global distribution which affects all ages and both genders. However, similar to other autoimmune diseases, females are more likely predisposed than men. And the occurrence of autoimmune hepatitis varies among ethnic groups, and it has been associated with genetic predispositions that can differ between races and between age groups within races. Um, On estimates of the natural history of autoimmune hepatitis, the 10-year survival is 80 to 90% for the treated and 67% for untreated patients. In the Philippines, autoimmune hepatitis has not been extensively described, and to date, there are little studies of autoimmune hepatitis among Filipinos. However, I have found a study made by Yu and Yap done in 2018 that described the clinical profile of Filipino patients with autoimmune hepatitis. So, um, according to Yu and Yap, the prevalence rate of autoimmune hepatitis seen with liver disease at National Kidney Transplant Institute was 0.62% with a confidence interval of 95%. There were 20 cases among 3,243 who had liver disease from January 1, 2004 to December 31, 2014. And the average age of the patients was 38.55 plus or minus 17.62 years old. And 13 out of the 20 or 65% were female with a female to male ratio of 1.85:1. And also it was found that female patients were older with a mean age of 41.54 years old as compared with the male group mean age of 33 years old. So for the immunopathogenesis of autoimmune hepatitis, the root cause of this disease is ultimately not super clear. However, research says that autoimmune hepatitis is a consequence of genetic predisposition, antigenic exposure, and various factors that affect autoantigen display, immunocyte activation, and effector self-proliferation. And the weight of evidence suggests that progressive liver injury with patients with autoimmune hepatitis is the result of cell-mediated immunologic attack directed against the liver cells in a setting of a loss immunologic tolerance for self-liver antigens. So the CD4 helper cells is the principal effector, and its activation is the initial step in the pathogenic pathway. And once they are activated, they are capable of becoming sensitized to hepatocyte membrane proteins, and also they can destroy the liver cells. And the explanation to the loss of self-tolerance may be due to molecular mimicry. However, this mechanism has not been established. And also, abnormalities of immunoregulatory control over cytotoxic lymphocytes may play a role as well. So, evidence to support an autoimmune pathogenesis in this type of hepatitis includes the following, these five. So the first one is that in the liver, histopathologic lesions are composed predominantly of cytotoxic T cells and plasma cells. The next is circulating autoantibodies such as nuclear smooth muscle or thyroid. Also, rheumatoid factor and hyperglobulinemia are common. The third one would be other autoimmune diseases occur with increased frequency in patients and their relatives who have autoimmune hepatitis as well. The fourth one would be histocompatibility haplotypes associated with autoimmune diseases are common in patients with autoimmune hepatitis. And the fifth one would be this type of chronic hepatitis is responsive to glucocorticoid or immunosuppressive therapy. And for the last bullet, humoral immune mechanisms have been shown to play a role in extrahepatic manifestations of autoimmune and idiopathic hepatitis, such as arthralgia, arthritis, glomerulonephritis. And it appears to be mediated by the deposition of circulating immune complexes and infected tissue vessels, followed by complement activation, inflammation, and tissue injury.
Okay. Okay, next.
So many of the clinical and laboratory features of autoimmune hepatitis are similar to those of chronic viral hepatitis. As listed in Parsons, common manifestations are fatigue, malaise, anorexia, amenorrhea, arthralgia, which is present in our patient, an extrahepatic manifestation, and jaundice. There was a study, retrospective prevalence study done by again Docu and Docyap, entitled Clinical Profile of Autoimmune Hepatitis Among Filipino Patients, which were and seen in the section of gastroenterology of the Department of Internal Medicine of National Kidney and Transplant Institute, or NKTI, from 2004 to 2014. The most common clinical manifestations of these patients were: first will be jaundice, second will be asymptomatic transaminitis, which is present in our patient, wherein there is an elevated ALT with no hepatic manifestations, and the manifestations are just mild with less than or equal to 5 times the upper and abdominal pain. Among these patients, the most common comorbid illness was hypertension, which is also present in our patient. For laboratory features, some subset of patients with autoimmune hepatitis are young to middle-aged women, which our patient belongs to is 50 and female, with marked hyperglobulinemia and high titer circulating ANAs. The serum ALT will be increased, serum bilirubin and ALP are increased, serum albumin will be decreased, and other markers which are important for the diagnostic criteria will be the polyclonal hypergammaglobulinemia with greater than 2.5 grams per deciliter. There will also be positive ANA. So, to emphasize, some of the diagnostic criteria for autoimmune hepatitis will be the autoantibody present, the serum IgG level, the typical or compatible histologic features, which will be discussed on the next slide, and the absence of viral hepatitis markers. For the histopathologic features of autoimmune hepatitis, there will be an interface hepatitis or piecemeal necrosis as seen in this picture, wherein there will be expanding portal tracts and extending beyond the plate of periportal hepatocytes into the parenchyma. These are mononuclear infiltrates which with included plasma cells. There will also be evidence of hepatocellular regeneration or the hepatocyte rosette formation as seen in this yellow slide. Septal thickened liver cell plates and regenerative pseudolobules. Septal fibrosis, bridging fibrosis, and cirrhosis can also be seen.
Morning, everyone. So
Good
today I will
morning.
be discussing the types of autoimmune hepatitis and the complications of this disease. So type 1, so autoimmune hepatitis is classified into your type 1 and type 2 based on the patterns of the circulating antibodies. As seen in the table, type 1 autoimmune hepatitis is more common in younger women and it is prevalent in North America and Northern Europe. So this is the list of the um, antibodies present in type 1 autoimmune hepatitis. The first two, your anti-nuclear antibody and your anti-smooth muscle antibody, according to Robbins, this would be the most associated antibodies in type 1 autoimmune hepatitis. While in type 2, which is common in children and teenagers and among the Mediterranean population, the main serologic markers will include your anti-liver kidney 1 emphasized in red because the other types, like type 2, which is seen in drug-induced hepatitis, and type 3, which is seen in chronic hepatitis D infection. And the other serologic marker for type 2 would be your anti-liver cytosol 1 antibodies. So another way to differentiate the two types of autoimmune hepatitis would be your human leukocyte antigen gene complex association. So it's short for HLA. So as we could recall, your HLA is a type of gene that is located in your chromosome 6 that regulates the immune system. So basically, these letters is a code to where you could actually find these genes. So type 1 would have HLA-DR3 or DR4 or DRB803, while in type 2, it's associated with HLA-DRB1 and DQB1. According to Harrison's, type 1 autoimmune hepatitis has marked leukoid manifestations, which is why it was used to be called leukoid hepatitis. And there is also hyperglobulinemia. In type 2, according to Schlesinger, this one is usually usually comes along with um, other autoimmune diseases. Yes,
Yes,
Doc?
Dr. Ruiz.
Yeah, since you came from module 4 already, can you review to us or to the class what do you mean by leukoid manifestations?
So, Doc, when you say leukoid manifestations, these would involve symptoms associated with lupus erythematosus. So this could probably involve arthralgia or joint pains, swollen joints, such as seen in arthritis, prolonged or extreme fatigue, and skin rashes, along with ankle swelling and fluid accumulation.
Okay, of course, there are other manifestations clinically, no? Among that would be your rashes, malar rash,
Ah,
etc.
yes, Doc.
The reason why I asked that is to correlate to one of the presentations of this patient, why autoimmune hepatitis is considered, which I hope you will mention. It will be mentioned by the last speaker. Okay.
Yes, Doc. Okay,
Okay,
so let's
go on.
proceed to the complications of autoimmune hepatitis. Since according to the epidemiology, females are more commonly affected by autoimmune hepatitis. So it is important for us to know the complications symptoms during pregnancy. So according to Schlesinger, spontaneous abortion and preterm deliveries are greater among patients with autoimmune hepatitis. And also, flares could occur during pregnancy and during pregnancy and postpartum, which is why immunosuppressive medications should be continued. So I was actually interested by this statement. So I checked PubMed. I was able to find a paper about it. So this paper over here is a retrospective study done in Portugal in 2016. So basically, the study involved 9 pregnant patients with autoimmune hepatitis, all of which were given their immunosuppressive medications. So the outcome of the disease is that 3 out of the 9 patients had spontaneous abortions, while the remaining 6 had live births, 2 of which were preterm deliveries. So basically, the the researchers recommended that there's actually a good obstetric outcome among patients with autoimmune hepatitis. But the fact is, there should be tight monitoring and control of exacerbations so that prognosis would be good.
Yes, Dr. Chan.
Yes, Doc.
Rafael, what kind of immunosuppressive agents were used on these pregnant patients?
So, Doc, according to the study, Doc, 8 of them received prednisone. Well, and yung iba po combination siya. So, um, 8 of them received prednisone and yung iba po combination with azathioprine po.
All of these were continued from the first trimester up to the third trimester of pregnancy.
Yes, Doc. Except for the first 3, Doc, na nagkaroon ng miscarriage po.
Because although the results are, of course, good, this just involves 9 patients.
Yeah,
and
Doc.
you can make firm conclusions on this study. Anyway,
Okay
thank you.
po. Thank you, Doc. So, the next complication would be cirrhosis. So, according to Harrison, yes, Doc. Sige. So, the next complication would, yes, Doc.
I'm okay.
Okay, sige po. So, our next complication would be cirrhosis. A while ago, Harrison's defined autoimmune hepatitis as a process involving a continuing hepatocellular necrosis and inflammation, which would eventually lead to cirrhosis and liver failure. So, Schlesinger said that around 7 to 40% of patients treated would develop cirrhosis. This depended on the frequency of relapse, treatment failure, and incomplete response. 13% of the patients with cirrhosis developed esophageal varices, and upper bleeding of any cause occurred in 6% within 5 years of treatment. Okay, so the next complication would include malignancies. As you could see, we have an emerald ribbon and the black ribbon. So the emerald ribbon is the ribbon for liver cancers, while the black ribbon is for skin cancers, it both involving melanoma and non-melanoma skin cancers. So let's start with hepatocellular carcinoma. So according to Schlesinger, hepatocellular carcinoma occurs only in 1.1 to 1.9% of patients with autoimmune hepatitis, cirrhosis, which is why he mentioned that this was insufficient to justify a formal tumor surveillance strategy. However, he listed a list of patients at risk for developing hepatocellular carcinoma, which included patients with long-standing cirrhosis for 10 years, those manifesting with portal hypertension, persistent liver inflammation, and immunosuppressive therapy for 3 years. And with this, he said that hepatic ultrasound every 6 months in such patients is a reasonable consideration. So aside from hepatic malignancies, we have extrahepatic malignancies, which occur in around 5% of patients. So the most common extrahepatic malignancy would be your non-melanoma skin cancers.
Good morning po.
Good morning. Go on, listen.
Good morning. So, this is a diagnostic algorithm for autoimmune hepatitis. So, um, the diagnosis requires predominant elevation of AST level with the necessary exclusion of other hepatic diseases, especially the PBCs, Wilson's disease, hematochromatosis, alpha-1 antitrypsin deficiency, drug use, or alcoholic hepatitis, and viral hepatitis. Being thus said, AMA antibodies should be absent and serologic markers HAV, HBV, HCV should be negative. For histologic findings, interface hepatitis should be present on histologic examinations as well as cell infiltrations, hepatocyte resets, and centrilobular necrosis. Laboratory manifestations of immune reactivity should be evident by abnormal elevation of serum gamma globulin or immunoglobulin. So the presence of ANA, SMA, and anti-LKM1 should be elevated also. So the degree of immune reactivity and presence of confounding etiologic factors such as alcohol and drugs, blood product exposure is distinguished between the definite and the probable IAH. So in classification of type 1 and type 2 are based on the type of autoantibodies that predominate in the disease. So this slide is a scoring criteria. On your right is an original scoring system proposed by International Autoimmune Hepatitis Group, which accommodates the diverse manifestations of autoimmune hepatitis. So it renders a score that reflects the diagnosis before and after glucocorticoid treatment. It is also provides comprehensive template of systematically assessing all features of the disease and accommodates diagnosis of patients with few or atypical manifestations. In comparison with the simplified scoring, it has been developed based only in 4 clinical components that include presence of and level of autoantibody expression by indirect immunofluorescence, then serum immunoglobulin concentration, histologic features, and viral markers. So,
Absence of viral.
the yes
You
po.
mean absence of viral markers.
Yes. Uh, HAV, HBV, HCV po.
Okay.
So the original scoring is useful for evaluating patients whom every component must be assessed, while the simplified is useful for excluding autoimmune hepatitis in patients with mixed immune or non-immune features. So, but diagnosis by scoring never overrides the clinical judgment. For treatment, the mainstay management of autoimmune hepatitis is glucocorticoid therapy. Prednisone in combination with azathioprine is the preferred treatment strategy, but therapy with prednisone alone is as effective as the combination regimen but is associated with a higher frequency of glucose side effects. In some patients, there are medical refractory cases, so there is an attempt should be to intensify the treatment with high dose of glucocorticoids or combination of glucocorticoids plus high dose of azathioprine. So other patients that have refractory to this regimen may be treated with cyclosporin, or mycophenolate. So like other patients with chronic liver disease, patients with autoimmune hepatitis should be vaccinated against hepatitis A and B, ideally immunosuppressive therapy is begun. So these are outcomes of treatment
Okay.
with the
We
conventional
probably can
glucocorticoid
skip
therapy.
this, Lisel.
Okay.
So
Sige.
as the last member, why do you think your patient has probably uh, autoimmune hepatitis is the cause of the mild elevation of your ALT?
So factors that weigh in favor of the diagnosis include female gender, the predominant elevation po, the presence of arthralgia, we can also consider po the absence of viral markers and no history of alcohol intake.
Have we ruled out hepatitis B? May viral markers
Ano
na ba
po?
tayo? Do we have viral markers?
Wala po.
Wala pa. Okay.
Wala
So
po.
we cannot rule that out.
Okay.
Okay. Sige, let's
Thank
go
you
to the
po.
next group.
So for non-alcoholic fatty liver disease, it requires a demonstration of increased liver fat in the absence of hazardous alcohol consumption, which is greater than a drink per day for women and greater than 2 drinks per day for men. So the defining feature of non-alcoholic fatty liver disease is the macrovesicular fat accumulation in more than 5% of hepatocytes. So this encompasses a spectrum of liver pathology with different clinical prognosis. So the first would be hepatic steatosis, which is the simple accumulation of triglycerides within the hepatocytes. So this is the most clinically benign extreme of the spectrum. On the other hand, we have cirrhosis and primary liver cancer, which is the most clinically ominous extreme of the spectrum. And in the middle, we have non-alcoholic steatohepatitis, which requires hepatocyte ballooning degeneration and lobular inflammation to meet its criteria. So this is the most common chronic liver disease in many parts of the world, but since majority are asymptomatic, the exact prevalence rate is unknown. But studies suggest a wide range from 2.8% to 46%. So this is strongly associated with obesity and insulin resistance, as seen in the rise of prevalence in concert with rising rates of obesity and DM. So most cases are discovered during the 4th to 6th decade of life, and it is more common in men, with a later peak of prevalence in women, suggesting a relationship with sex hormones and menopause. So ethnicity also plays a factor, since in studies it was found that Hispanics were more affected than Caucasians, and the African Americans were least affected. So for the prevalence rate in the Philippines, I found 2 studies uh, which stated prevalence rate of 12.2% and 39.78%.
So next, good morning po, Doc. For the clinical features, as mentioned earlier, the majority of patients are asymptomatic. So that's the most common presentation. Patients do not have symptoms. For the signs that are common, usually patients are seen to have hepatomegaly. However, in some patients, this is difficult to palpate since, as mentioned earlier, there is an association of NAFLD with obesity. However, that does not mean that NAFLD does not occur in lean patients. So NAFLD can occur in both obese and lean patients. In NAFLD, there's also the presence of mild to moderate elevations in several lab parameters, such as ALT and AST, alkaline phosphatase, and serum ferritin. We should note here that the AST to ALT ratio is less than 1 in most patients, which is in contrast to alcoholic hepatitis, where the reverse is true. ALT is greater than AST in those cases. AST is greater than ALT and alcoholic hepatitis. Uncommonly, patients may present with some symptoms such as vague right upper quadrant pain, fatigue, and malaise. For the signs, these are uncommon signs that are stigmata of chronic liver disease, including splenomegaly, spinal telangiectasias, ulnar erythema, and ascites. So the presence of these signs usually connotes that the patient already has an advanced liver disease. Uncommonly, patients may also have low titer anti-nuclear antibodies. This is an uncommon finding. So next, there are many conditions that are associated with NAFLD. So the conditions that were found to be strongly associated with this disorder are listed on the left. So we have metabolic syndrome and obesity, diabetes mellitus, hypertriglyceridemia, hypertension, and cardiovascular disease, with the latter stated in Schlesinger as the primary cause of death in patients with NAFLD. So aside from that, there are also many other conditions shown on the right that are associated with NAFLD. And generally, according to Harrison's, it is stated that NAFLD has many deleterious effects on health in general. And you can also notice that a lot of the conditions associated with NAFLD are endocrine in nature. So next, for the progression of patients with NAFLD, the vast majority only present with an isolated fatty liver. In that case, patients have a mortality rate that is not too different from that of the general population. But otherwise, once they start developing NASH or non-alcoholic steatohepatitis and so on, once they develop these more severe forms of NAFLD, their mortality rate and life expectancy is less the life expectancy is less than that of the general population, but their clinical outcomes compared to alcoholic hepatitis are better. So only a small minority of patients with NAFLD go on to develop NASH, and from that population, a smaller subgroup go on to develop cirrhosis, eventually decompensating, and with some also developing hepatocellular carcinoma. So some factors have been shown to increase the likelihood of progression to more severe forms, which are obesity, insulin resistance, and diabetes mellitus. So some of these have been shown to also serve as risk factors for the development of NAFLD and its progression.
Hello po. So, for diagnosing NAFLD, it requires demonstration of increased liver fat in the absence of hazardous levels of alcohol, which was defined earlier as not more than 2 drinks in men and not more than 1 drink in women. Other causes of fat accumulation and liver injury must also be excluded from the diagnosis of NAFLD. Establishing a diagnosis of NAFLD does not require invasive testing. It can be accomplished by history and PE, liver imaging, and blood tests. For liver imaging, ultrasound is the first-line imaging test to diagnose NAFLD. On a normal ultrasound, the liver is seen as either hyperechoic or isoechoic compared to the renal cortex. So orient ko lang po kayo, this one is the liver and this one with the RC is the liver cortex. But in fatty liver, the liver is described as bright due to increased echogenicity as compared with the renal cortex. While on CT, the fatty liver is lower in density as compared with the spleen and demonstrated by a negative Hounsfield unit, which we have learned in radiology. There are only two tissues that can produce a negative Hounsfield unit, and that is air and fat, seen here. So this is the liver, and then this is the spleen. As you can see here, the liver has a negative 16 Hounsfield unit. And for MRI, fat appears bright on T1 weighted imaging. And on CT although CT and MRI enhances sensitivity for liver fat detection, it adds expenses to the patient. Currently, there is no specific blood test for NAFLD, but we can expect abnormalities in the ALT levels as well as liver function tests such as hyperbilirubinemia, hypoalbuminemia, and PT prolongation. However, it is important to note that the liver may not be enlarged and the blood tests may be completely normal in patients with NAFLD, which is why confidence in diagnosis is increased by the identification of the risk factors mentioned before. So for staging is important in prognostication as well as determining the treatment for a patient with NAFLD. So it is divided into two, invasive and non-invasive. For non-invasive, it is composed of three factors, which are the blood tests, imaging, and the PE. Blood test evidence of hepatic dysfunction includes hyperbilirubinemia, hypoalbuminemia, PT prolongation, and thrombocytopenia, as I mentioned before. While on PE, there is the presence of stigmata of portal hypertension, which are spider angiomata, palmar erythema, splenomegaly, ascites, clubbing, and encephalopathy. The only test under invasive is liver biopsy, which is the gold standard for staging of NAFLD patients. Complications are rare, but there is a potential sampling error if tissue core is less than 2 cm, and it also cannot determine progression and regression of the pathologic processes. Due to these limitations of liver biopsy, there is increasing efforts in developing other non-invasive approaches to staging NAFLD, such as algorithms that combine various laboratory tests like Enhanced Liver Fibrosis Score, BARD score, NAFLD fibrosis score, and the APRI score. Combining these tests with new imaging approaches that permit non-invasive quantification of liver fat and liver stiffness, like magnetic resonance elastography or the transient elastography, it increases their predictive value. So, new tools are being used to serially monitor fibrosis progression and regression in NAFLD patients. As a result, liver biopsy staging is becoming restricted to patients who cannot be stratified using non-invasive assessments. So for the treatment is divided into three components. There is the specific therapy for
Could you move
NAFLD
your
related.
Chantal? Could you
Po,
move your slides? It's not
yan po,
showing.
Doc. Ay, no, hindi po Ayan po, Doc. Nag-move na po ba? Okay. So for treatment, it's divided into three components. The first one is specific therapy for NAFLD liver disease. The second is treatment for NAFLD associated comorbidities. And the third is treatment for the complications of advanced NAFLD, which involves management of the complications of cirrhosis and portal hypertension, including primary liver cancers. So there are no current Food and Drug Administration approved therapies for the treatment of NAFLD. So current approach to treatment focuses on treatment to improve the risk factors for NASH. So the first treatment option is diet and exercise, which is the foundation of NAFLD treatment. So, weight loss of 3 to 5% improves steatosis, and weight loss of at least 10% is needed to improve steatohepatitis. Diet and exercise also improve serum aminotransferases. So, the second treatment option is pharmacologic therapies, which is an area of active research because currently there are no specific drugs that can help with NAFLD. So in metformin, it improves hepatic insulin sensitivity. However, it does not improve liver histology, so it's not currently recommended for NASH. For thiazolidinediones, it improves systemic insulin resistance. However, it's also currently not recommended for NSH. For antioxidants like vitamin E, it improves NASH histology in pediatric patients. However, long-term treatment increases risk for cardiovascular mortality. So, so vitamin E should only be considered as a first-line pharmacotherapy for non-diabetic NASH patients. The third treatment option is bariatric surgery, which is generally safe in individuals with well-compensated chronic liver disease and improves hepatic steatosis and necrotic inflammation. However, there are some studies that suggest hepatic fibrosis might progress after surgery. So the final treatment option is liver transplantation, which is reserved for patients with NAFLD who have end-stage liver disease. Outcomes are generally good, but comorbid medical conditions mentioned before often limit transplant candidacy, and in liver transplantation, NAFLD may recur after. So finally po, we considered non-alcoholic fatty liver disease because,
Yes,
yes
Dr.
po,
Chan.
Doc.
Before you move on, Chantal.
Chantal, so
Apo.
in all the treatment modalities that you have mentioned, what is the most important therapeutic modality that must be started in all patients with NAFLD or NASH?
Ano po, Doc? It's diet and exercise po.
So
Diet and
what
exercise.
does diet and exercise lead to?
It improves po serum aminotransferase, steatosis, and steatohepatosis po, Doc.
Yes. So there has to be weight loss.
Opo.
Okay.
How
And
much?
you read on the recommended weight loss in patients with steatosis and those who have steatohepatitis?
Okay, Doc. For steatosis po, recommended weight loss should be 3 to 5%, while in steatohepatosis, weight loss is recommended, at least
Steatohepatitis.
10% weight loss is recommended
Okay.
po.
Okay, that has to be sustained, di ba? It has to be
Opo.
sustained. Now, why don't you use vitamin E in male patients?
Um,
Especially if it's prolonged.
uh,
And
um, in prolonged treatment of vitamin E po kasi, Doc, there is increased morbidity for there is
What
increased
else?
cardiovascular mortality po.
Anong meron sa lalaki na wala sa babae?
and at the age of Dr. Chan.
Male infertility po, Doc.
No,
No, no, no.
no. Dr. Chan is definitely fertile.
Very.
Risk po, Doc.
And,
Very. Prostatic.
prostate cancer, okay?
Okay po,
Sige.
Doc.
So, there's a higher incidence of prostate cancer among males taking vitamin E. Okay, so what do you think? Why is your patient having elevated ALT?
So we considered NAFLD po kasi the patient is a 50-year-old obese woman presenting with increased ALT with prior history of elevated blood sugar and episodes of BP elevation, which are all associated risk factors for NAFLD po, Doc.
Okay,
Yes po.
where's the analyst group?
So, Doc, yung final part na lang po ng report.
Yes.
So, Doc, yung final diagnosis. So, since we just discussed the three diseases, which all showed the increase of your transaminases. So, that's why all three were considered. Chronic viral hepatitis was considered because her occupation and the prevalence of hepatitis in our setting. Aside from that, uh, autoimmune hepatitis was also considered because of um, her comorbid condition of hypertension and her her gender. So they all showed, as I mentioned a while ago, an increase of your serum ALT and yes po, Doc.
Yes, doctor.
Yeah, Angelo, I think what you should tell us is what is your primary diagnosis because it was discussed already a while ago, all of those.
Okay,
So,
Doc.
for this particular patient, what
So,
is your
Doc,
primary diagnosis? And then tell us later on that maybe the other two cannot be totally ruled out. So,
okay po,
given
Doc.
the case, what would be your primary diagnosis?
So given our patient and her profile, we can say our most likely diagnosis would be our non-alcoholic fatty liver disease. This is so because she fits into most criterion or most risk factors for the disease, and aside from that, uh, we can say that the other two diseases cannot be specifically ruled out because they are still lacking or the information given was still incomplete. The viral load or the um, antibodies were not given, so we cannot say or we cannot completely rule
Not
out
the
the other two
antibodies,
diseases.
but the serologic test for chronic hepatitis B. You need to determine serologic test for chronic hepatitis B. Okay, I think.
Okay. So thank you very much. You did a good job. Thank you,
Thank you po,
everyone.
Doc.
So, Dr. Romana.
Yes, look, I think we can I'll just bring up the next